land of ours is a land of many people, a land of peace. But even peace has its price.
This is an audio transmission from Cold Light Legacy.
This is Dr. Jason Bechter with a very special Accelerating the Basement episode where myself and some of my buddies from Cold Light, which is our umbrella group for Photon and all these other doohickeys we do in our spare time, so much spare time, we are here today to discuss the actual town hall that ASTRO had over the SUPERVISION issue. Now, a couple things about that. So this was an actual town hall. It was mostly engagement, which was wonderful, and I hope we get to do that again. And as such, unexpectedly, this was dense. So I had planned to just fire off a reaction episode like I have in the past, but this was a behemoth. There was so much here. And so I've been working on this since it came out, obviously, or since the town hall happened. We did two things. So one, unexpectedly and totally unplanned, myself, Dr. Todd Scarborough, Dr. Matt Spraker did a immediate post-town hall reaction episode. And that's what is interspersed here. So there's going to be me doing my normal thing, reacting to sections, and then you're also going to hear me and Todd and Matt and interspersed throughout. We did that call, and it's important to note, one, that we did that. It was Friday night at whenever it ended. We did it at Friday night at 6:30 or 7 p.m. So I was here at my house in rural Vermont, and actually it was a vacation day for me, but this is how much I love radiation oncology. Todd was at his house in Tennessee, having gotten home from clinic. Matt was walking from his hospital to his car and then did the rest of it in his car in a moving vehicle in Denver, Colorado, with questionable cell service. Not really sure if he's actually in Denver. When I go to Denver, the cell service seems better than what he had. But alas, maybe it's my favorite, the sunspots. But so we did all that through technology. We did a virtual cross-country, unplanned, impromptu episode, and technology enabled us to do that, just like it enables us to deliver safe and effective care for our patients wherever we physically are when radiation therapy is delivered. But I would normally say that's neither here nor there, but that is everything. And so point number one is the magic of technology allowed us to do that. And then when I listened back to myself, one, it was, or I guess point two, it was a little bit more pointed than I like to normally do. That's mostly on me, not Matt, Todd. But three, this was so dense that when after editing everything on that first reaction episode, the hot take episode, and then editing it, I realized that this was so dense that even I couldn't quite remember all the details of the things we were reacting to. And so what I decided to do instead was, ever since, so it's been over a week now since that town hall happened, and I've been trying to slog through this, and I've then spliced up the hot take episode, plugged it in here, and then have been going ever since, because there was just so much in this that I didn't think it was very fair for the people who didn't even go to the town hall and then be like, what in the heck are these guys talking about? And so this way we can all at least be on the same page. And one thing I will note is that there was a very active chat in this Zoom meeting that I am not reacting to because that's a whole other can of worms, but maybe that'll be a future episode. But so that's when you hear the Geiger counter of transitions, that's what's going on. And you can tell the hot take episode versus the regular reaction I was using a different mic. We were on a different platform. I tried to keep this as brief as possible. I edited the heck out of the town hall. I removed a lot of the dead air and the setup and the transitions. And so I was able to cut down the actual meat of the town hall to, I think, somewhere around 35 minutes. And this is still obviously a gargantuan episode. I thought about hacking this up into multiples, but I think it's better if I just leave it as one, and I'll either try to put in bookmarks, or I just know it's hard to listen through all these things. And if you guys have a better mechanism for me to make these things more digestible, short of making multiple episodes, I'd love to hear it, because I'll try to, maybe I'll put bookmarks in the description. But anyway, so we're going to start off with, I'm going to run through the slides, the poll that was at the beginning, and then we'll go from there. But this was a doozy. So they opened with this platform I've never seen before. Now, again, ivory tower echo chamber stuff. I don't know if they use this Slido thing. I've never heard of it. I've never seen it. It was not intuitive. So a bunch of us had issues where you open up a browser, you go to the Slido website, you enter the code. So I did that. And then it says this this was not found. But if you look, there's like this grayed out hyperlink that would pop up further down that you could click on. I don't know if you people, I mean, the inside of ASTRO, if you guys use this all the time. The rest of us have not seen this. I don't know. Many of us have issues with that. But so they opened and did not tell us they were going to open with this slideshow poll thing. So it was pretty rapid fire where it started, and they're like, here's Slido, here's the code, go to it. And heaven help you if you have never heard of this before. So then they rapid fire ask questions. Now, I like speed for the most part, and it was the most rapid poll I've ever had. But just to run through these questions here from the slide. So the first question was, which best describes your practice setting? And they gave you 3 choices: community hospital, academic medical center, and freestanding. So community hospital was 49%, academic medical center was 45%, and freestanding was 6%. And this was one of the lower ones, unfortunately, where there's only 47 respondents, which is actually pretty good. But again, highlighting my point that freestanding is the super minority now. So 6% is the lowest I've ever seen. Now, I think that was probably an artifact of not only the people on the town hall, but the people who had figured out Slido this quickly on the town hall. But I have also recently seen in a survey about telemedicine and RadOnc, of all things, that there is 10% freestanding. So I think I'm going to continue to downgrade my estimate, where I'd previously been saying, based on the 2020 COVID survey that ASTRO did, maybe 20% of practices in radiation oncology are now freestanding. I'm going to take a stab in the wind here and say it's probably 10 to 15%. And that's okay, because there's no freestanding. It's not private practice. Freestanding does not need to be saved. Freestanding is a billing mechanism. And we hear about it a lot because people in authority in ABR and ASTRO were also in authority at 21st Century Oncology turned Genesis Care. So there's an outsized discussion on that fact. Not to say that there's not other ones and that it's not important, but the majority of us are in hospital outpatient departments, whether we're community, private practice, academic, satellite, you name it. Hospital outpatient reflects the majority of us. Question 2, with about 53 respondents, was which described your practice location best? We had urban, suburban, and rural as choices. So 55% urban, 32% suburban, and 13% rural, which is incredibly reflective of other data. And question number 3, with 52% respondents, 52 number of respondents, I think supervision requirements should include common sense flexibility to allow for other professional activities, tumor board, OR time, etc. That was 100% in agreement. Very unsurprising. And question number 4, I don't think supervision requirements impact quality. Disagree with 58%, agree with 40%, no opinion with 2%. That was with 53 respondents. Question number 5, I am concerned about the proliferation of radiation oncology. Agree is 63%, disagree with 35%, no opinion was 2%. Question 6, direct supervision leads to physician burnout. Agree 52%, disagree 42%, no opinion 6%. That was 67 respondents. People were clearly figuring out the Slido. So question 7 was, I feel like direct supervision is out of place in the modern era. And with 60 respondents, 52% agree, 48% disagreed, and 0% had no opinion. So that was the most split. And then the final question of this one was, I am concerned that virtual supervision will lead to lower reimbursement, with 63% saying agree, 33% saying disagree, and 4% having no opinion. There was 1 or 2 more for later in the presentation. We'll mostly skip, but except for one, which was incredibly infuriating. The question was, which supervision policy do you support? The 4 choices were direct with rural, clinical, and personal flexibilities, or direct with rural and clinical flexibilities, or general or direct. Now, conspicuously absent was virtual direct, which is a choice, and it's actually a choice that every other specialty society which has authored anything that I can find in any sort of public-facing environment supports. This is how you cook the books. Could you try harder, please? Seriously, could you try? The most popular answer of the limited answers, inappropriately limited answers, 72 respondents and 39% of those respondents had direct with rural, clinical, and personal flexibilities. Now, that is incredibly interesting that because the next most popular one with 31% was direct with rural and clinical flexibilities. So 8% of you people think that it's okay for rural and clinical flexibilities, but not personal. I'm going to hope that you read that fast because what? That doesn't even make, I'm not even going to speculate, but this poll is useless or this particular question because you left off virtual direct, which is what I would have chosen. So on that, let's get into it.
Really, there are two distinct issues, although I think these are kind of being confused as one. The first has to do with our weekly management code, often called an on-treatment visit, OOTB, CPT code 77427, and whether or not this should remain on the telelist. And the second issue is what level of supervision should be required for radiation therapy. I think it's worth discussing the letter. This was tricky because we wanted to post it and give it to the members as a part of full transparency. That being said, we write about a dozen of these letters a year, if not more. And there's a specific language that the agency is used to seeing. And they read things probably different than we would or the general public would. And so we did take into account rural practices and patient care responsibilities. And it was actually in the letter. And it was the language that we used was there should be practical flexibilities for radiation oncologists to participate in tumor boards and other clinic responsibilities for the good of patient care, as well as latitude to ensure that patients in rural areas have access to treatments. And they have a specific way they define rural areas. And there were specific responsibilities we wanted to specifically carve out under the immediately available and interruptible. And so that's where this paragraph specifically addressed. And the agency definitely understood this when we've had follow-up with them.
That doesn't even make any sense. So that saying that, we write so many letters per year that we just 12 letters a year, where there's no way we could have had a conversation about this with you people first. That's a bizarre excuse. It's a pretty weird explanation of one, we send so many letters. And two, the agency is used to seeing things in a certain way in the general public. What are you saying? I understand wanting to hide how the sausage is made, as it were, just like how when I do Freedom of Information Act request, and for anyone who's done the FOIAs as well, there's a exemption. So the government doesn't have to give you everything always. They will frequently use B5 exemption, which is for, let's say, some person who may live in New England may send a bunch of FOIA requests into CMS about ROAPMs and protons and things and so on and so forth. And the CMS might send you something back, and a lot of it may be redacted with a B5 exemption because the government allows for agencies to keep things secret, as it were, in terms of letting government employees and officials feel like they can talk a process out and not have all of the gory details released to the public later on. And that's why Student Doctor Network has the business forum. That should be why ASTRO has RoHub or RoHub. And there are mechanisms in this, and it's not an explanation. If you say, we ran it through people, we ran it through committees, and so therefore we talked about it. No. Okay. No. So I'm obviously recording this over time because this is a beast of an episode and I actually have a real job. And today, when I'm recording this, ACRO sent out a member survey, and ACRO has sent that out previously. Now, we'll see what ACRO ultimately does and what choices they make about what they do and do not say, quote unquote, behalf of the organization. But this is very easy. This is not reinventing the wheel. The blueprint exists, okay? There's a way to do this. But many organizations across many industries do this all the time and have for decades. Maybe one of them can help you out.
And so at this point, I'll turn it over to Kate Yashar for member feedback.
Well, thank you, everybody, for all the feedback we've received on supervision. We've heard comments supporting and comments opposing ASTRO's position, and we've heard lots of comments for the middle ground. And of course, there's a number of areas where there's broad agreement. Key among them are we all believe in patient safety and quality. We all have concern regarding the use of mid-levels and where mid-levels are going to be in the future of medicine, reimbursement challenges that might be affected by supervision, and engaging flexibilities, especially for rural practices. There are other areas that warrant further consideration, including the questions about the data quality related to adverse events, and are they picking up near misses and misses as well, flexibilities for personal emergencies, and concern about just being there to babysit the Linux. So I hope you've had a chance to review the frequently asked questions we posted to the ASTRO website and that we shared also on the Astrogram. We put a link to that in the chat. Over the last few weeks, we've received a number of questions and comments from members, including a very robust discussion on AuroHub, which helped to inform the FAQs document. This document will be updated as new questions or issues arise, so anyone can see them on the website if you like. We also shared a blog post, the ASTRO Policy Engagement from Legislation to Regulation, written by myself and Ann Hubbard. It gives a background on CMS rulemaking and our internal process for engaging CMS, so you can get a better sense of how our ongoing actions with the agency happen. It also includes ways for ASTRO members to get involved in health policy efforts and opportunities to volunteer for these committees.
It's pretty alarming to me in a way to hear that ASTRO regularly engages with CMS, because from an outsider's point of view, it doesn't seem like anything really happens in a favorable way towards the specialty. Now, the claim can always be made that, well, we prevented worse things from happening, and just I can't refute that with any evidence. They can't support it with any evidence. So maybe that's the case. I will acknowledge that, but ultimately none of us will ever know. And as has been pointed out in other podcast episodes by other folks or in other stories or people, or maybe you yourself have experienced, this open invitation of, oh, volunteer for a committee. No, you can throw your hat in the ring, but the committees that they have, or the committees where things are actually done, in as much as you can call them that, those are closed. Those are friends and favors of the existing bubble. You're not getting into those. Maybe that will change, but if you don't know what I'm talking about, just go ask anyone who has tried to get on these committees, and you'll see what I mean.
Can you address whether I assume they means ASTRO wants all hospital-based settings to return to direct after CMS made general supervision permanent in hospitals on January 1st of 2020? And so I will turn that over. I don't know, Dr. Michalski, if you want to address that, or I'm certainly happy to.
Yeah, well, we do believe that radiation oncologists being in the clinic is important for the management of our patients. Things happen that often require a physician to become available, whether it be to see the patient in an exam room or at the treatment room. But yes, it's our position that a radiation oncologist should be available for patients who are receiving a course of radiation therapy. Now, that being said, we realize that there are situations where a physician will be taken out of the immediate treatment area. For example, they might be in the operating room to manage a patient getting brachytherapy, or they might be attending a tumor board or attending a quality improvement conference or a meeting at their hospital. And so they have to be available to attend to those clinical related activities. But still, we believe that the physician should be available for the patients who are receiving care during the course of the day. I don't know if others want to comment on that.
Just a reminder that these supervision rules are just around who is available when the linear accelerator is treating patients. If a patient is having an issue and needs evaluation, that's a separate thing. That's literally E&M, that's evaluation and management. Obviously, that's bundled in and considered part of 77427 in this case. But these are separate issues because, as Todd will point out later in this episode, and the best example is, let's say you have it's a slow day, you've got 8 on beam, and the linear accelerator is done treating at 1 p.m. and you leave for the day appropriately. And let's say you have a head and neck patient and they come back at 2 p.m. They got treated earlier that day and they went home and they just can't take it. They need to come in and get seen. When they come in at 2 p.m., who's going to see them? And that's the metaphor, the analogy for every argument they're making here. These are two distinct things. Evaluation and management of a patient is just that, evaluation and management. And the physical location of the physician, again, I need to always clarify that I personally, even though I have the option to do general and virtual and all these things right now, I do not, 99% of the time, it's direct supervision, because I think it's, and by that, or I would go a step further, 99% of the time, I am physically in clinic for the majority of the day. And if I am not, everyone has my cell phone, my 18 email addresses, my Teams, Zoom, FaceTime. I'm basically available 24/7 to a degree. And that is distinct from the CMS-defined levels of physician supervision as it pertains to billing CPT codes without committing fraud. And these are very different things.
I'll take a shot. Yeah, I think this is obviously the crux of the issue, and we understand certainly, lack of a better term, we've been in a supervision, almost nirvana the past few years, because I think what we've seen is physicians are able to basically dictate to manage their own clinics as they see appropriate. And I think for the most part, we've seen that physicians have done this quite well. And as this is part of the reason we didn't comment last year when the agency was talking about extending, because we saw that, physicians were doing a very good job. I think what changed here is that we now have to make a decision on what we're going to do with supervision. I think we all can agree that, do we need to be there 100% of the time? No. Should we be there 0% of the time? No. The answer is somewhere in the middle. And this is where we have a challenge, because the agency doesn't really do nuance very well. And so we have asked for a minimum threshold, and they want precedent, and we're trying to provide that. But so we do recognize there's a need for flexibility, and we have been pushing that with the agency. But it's very difficult to get nuance, because they're afraid of setting a precedent in radiation oncology and having it go throughout the rest of the field. And so we are working on it, but it's not as easy as it sounds, because the agency thinks about it for the entire house of medicine, not just radiation oncology.
That quick few sentences is everything. Let's repeat that a few times. So 1, the current situation of virtual direct in general is nirvana. His words, not mine. They are mine too. But number 2, physicians in this nirvana have been left to independently manage their clinics, and they've done so wonderfully. And that, to me, means they're the physicians that they've trained to be and are expected by society to be. And number 3, the agency does not do nuance. So we can't have this baseline level or threshold level of supervision, because it would be too confusing. Yeah, their solution is we should do direct supervision with flexibilities. What do you mean? With the word flexibilities, that's wildly problematic. That's actually the number one thing I have a problem with, is if you, a regulation like this, we should have direct supervision except for flexibilities, exceptions with flexibilities. Clearly, you have not read enough QI/TAM cases. Clearly, you have not been involved in them. Clearly, you have not been either a relator or a defendant in these, or an expert witness, in case you're a consultant with a billing company. And that is nuance. That is the definition of nuance. Of the two, let's have direct supervision with flexibility exceptions or exemptions, or a physician should be on site at least 90% of the time. Which of those has more nuance to it? I, for one, agree that the status quo is nirvana. We have all done an excellent job being doctors and being uniquely going against the grain, wherein the rest of the house of medicine is saying, let's keep virtual direct. And ASTRO's are saying, not only should we not keep virtual direct, let's roll back to direct supervision, but just for rad onc. What?
Thank you. And then I'll see the next one on Slido, or the up one, was, did ASTRO board discuss supervision before the letter was sent? There were many robust discussions in health policy and then government relations and then the ASTRO board. So there were, it was a robust debate, just like the debate is now, because people come from very different viewpoints.
No, something tells me that the debate or discussion that was allegedly had prior to writing that letter with only 2 signatures, only Dr. Michalski and the outgoing CEO, I don't think it was as robust as this one. I think the current actual conversation with the actual stakeholders in the community, I suspect this is a little bit more in depth.
But just like when we're voting today, when everybody voted and talked through the issues, this is what was felt to be the best going forward.
Wait, does that mean that the board, or there was internal votes? Are there meeting minutes that we can see, or maybe these votes themselves?
How would virtual supervision impact the workforce in general? How many fewer practicing physicians would be needed, if not required to ever be on site? I don't know that we've done the math on exactly how many fewer, but certainly virtual supervision would mean that you could cover many centers from your desk. And so I think that we could probably assume that may change the workforce.
Yeah, I would echo that, Kate, that the idea of having 100% general supervision opens up the opportunity for patient to go through a course of treatment without ever having to see their radiation oncologist. And I think that would be a very frightening situation. I think the opportunity to see a patient at least weekly during their course of treatment is very important. It has been a part of our practice for a long, long time.
Obviously, this is probably 18 episodes in and of itself, so I'll just try to be brief. I think it goes without saying that I have tremendous concerns of the workforce, and arguably one of a handful of individuals who has spent a significant amount of time over many years working on this and publishing and talking about this. And there's a few issues with the people who are concerned about the apocalyptic scenario of permanent virtual direct, or even just lowly general supervision. One, I also agree there's probably going to be an impact on the job market, but I think that has already started to happen, because again, we're 4.5 years into this, into general and into virtual direct. The things in this space that are going to affect the job market, they are not the things we're seeing. So everyone is worried about the startup bridge oncology, and startups in medicine don't do well. Medicine is a very highly regulated space. It's very difficult to succeed. Incumbents are incumbents for a reason. And antitrust laws were written to prevent incumbents from doing things for a reason. And I would pay very close attention to the voices we are not hearing on either side of this debate compared to what those institutions are doing or are publishing or have already done. And because the loopholes and exploits that people are worried about in terms of affecting the job market, those are happening and have been happening and are going to continue to happen regardless of the outcome of this conversation or this debate. And people seem to forget this is not, workforce economic concerns cannot happen in a vacuum. So absolutely, if this was a debate or an issue that could occur in isolation on a singular cause and effect macroeconomic scale, meaning that if we are in a vacuum and equilibrium, and the only change that is introduced is that a radiation oncologist must be on site physically anytime a linear accelerator is turned on. And the change is that a radiation oncologist does not have to be on site, that they can supervise virtually. Then yes, absolutely, by the strictest definitions and the laws of math and supply and demand, you would need fewer radiation oncologists. But that's not the world we live in. So number one, in this scenario of sitting at your desk covering many sites, patients not seeing radiation oncologists. So it is hard to build new linear accelerators. There are certificate of need laws that make it difficult to borderline impossible if you are not already an incumbent, or even if you are an incumbent, it's very hard. So for example, my residency institution, Yale, and a couple of the other Connecticut practices, they have been trying to build a single proton center in Connecticut. When I interviewed at Yale in 2015, the proton center was talked about to me then. It is still, I don't even think they've broken ground yet. It is 2024. And so that is one of the wealthiest institutions in the world, and teamed up with more than one other practice in the state, because the state of Connecticut isn't always the biggest fan of Yale. So it's with some of the more favored places. And even that has not gotten a single proton gantry built. To assume that there's going to be some proliferation of these ghost LINACs everywhere would presume that CON laws didn't exist, certificate of need laws didn't exist. But even if that wasn't an issue, the capital is a linear accelerator. If you already have the volt, and I can tell you this because I'm doing this right now, a new just baseline TrueBeam is going to run you a few $1 million. And that's assuming you need assuming if you have an existing volt that can accommodate new linear accelerator and minimal work needs to be done around that, you're talking more than a couple $1 million, we'll put it like that. So if you don't have that volt, then you're not just, it's not a cheap endeavor. We're talking $4, $5, $6, $7 million minimum. And then that gets into where you're getting that capital, and then where you're putting this new LINAC, is that in a place that can support, even if you get that through, is that even going to survive? And so you get where I'm going with this. We could just go down this rabbit hole forever. So if you're not going to be able to easily build a new legion of ghost LINACs, it would require a change in the workflow of the existing LINACs. And again, as someone who has worked in many different hospitals and seen cultures and things, and radiation oncologists should be doing, and usually are, more than just sitting around and just drawing circles on their computer and clocking out for the day. And it would be a massive change to the workflow and the culture of existing institutions and hospitals to all of a sudden have exclusively virtual radiation oncologists. And I'm not saying it wouldn't happen. It will absolutely happen. And it's probably already happened. But is that going to be the predominant force? No, not in any sort of limited time scale. And I think it's a reasonable thing to be concerned about. And I am also concerned about it, but it's just another drop in the bucket of my general concerns, where the real concern is the pipeline, is the number of new graduates being produced. Now, that being said, if we are willing, and I don't even think you have to be willing because we're going to be forced to do it, if you expand what the traditional definition is. So for the last 20 years, most people, that's by anybody's guess, of the ASTRO persuasion, view radiation oncology as a doctor who focuses on cancer, usually as a disease site specialist, or maybe 1 to 3 disease sites, who does primarily external beam treatments, and maybe you have a brachytherapist and you are responsible for contouring and treatment plan approval, and the other stuff is handled by the medical oncologist or the other doctors. That was the bubble, the weird bubble for the last 20 years. That's not going to work anymore. And I'm sorry for the people who wanted that, who were just starting out and thought that was the career they're going to get. If that's the career you think you're going to have, it ain't going to work. And on the supply and demand side, or on the demand side, if you do things like engage in radiopharmaceuticals or benign radiotherapy, or get involved in community things like lung cancer screening, or take on more, if you do what the other doctors have traditionally done, like all the other doctors, there is a bigger role for you as a physician. Because at the end of the day, people are very fond of saying we're doctors first, oncologists second, and radiation oncologists third. If you believe that, act like it.
Does ASTRO support different supervision requirements between hospital-based and freestanding? No, we would advocate that it be treated similarly, whether you're hospital-based or freestanding. Certainly, I think in the freestanding, where you might have one physician, we have talked to CMS about flexibilities to attend to clinical issues like tumor boards, or to do, a consult in the hospital, because we feel like that's important, and you can arrange your patients so that you don't have a patient where you feel like you might be called to the machine, or you need to see image guidance. You can arrange it so that you could step away to do those other clinical activities. So we have talked to CMS about that.
You can't square that circle, as the kids say. It's wonderful that we have Todd Scarborough on this, because I have tremendous concerns when somebody is saying, we're going to write this regulation, this national federal regulation, but it's going to be flexible. And that's how you get crucified in a Ketam case. That is what is going to be used in the next whistleblower case. It's, ASTRO promised me, or this says flexibility. Flexibility is what your lawyers want it to be.
Yeah.
And you can't do that. You can't.
I so wanted to chime in, and I just didn't want it to be about me, but I wanted to chime in and say, hey, Jeff, hey, Howard, hey, Samir, where were you guys going to CMS, telling them to be flexible in the MEMA case? Because I was there maybe 98% of the time. I'd like to say 99, but I would say somewhere in the 95 to 100%. It was certainly much more than 90% of the time. So why didn't you go to CMS and tell them, be flexible? He doesn't have to be chained to a LINAC. They don't have to babysit. Why didn't you say, hey, there's 100 other doctors there? Why didn't you come in and research what other doctors were there? Why didn't you come in and say, well, his RADONC partner was there. Surely he didn't have to be there. ASTRO didn't do that.
As I recall, I don't think there's any evidence of them doing anything from that time, other than maybe members taking quotes into the New York Times. And that's the issue about this. That's what's at stake here. And it's not safety. If you're going to make the safety argument, this is the extreme version, where if you're going to mandate this, the step before that is you need to come out and say, we need to be doing daily IGRT for every treatment all of the time, period. That needs to be the stance, because if this is truly a safety issue, then at minimum, we have this tool. We can do daily cone beams. And what you have to define what kind of safety issue is going to require a doctor to be physically there, because there's that letter in the stuff I put up on Fixshare and stuff. So 6 of the cardiothoracic societies came out supporting virtual direct. Those are the people who are in charge of things where minutes count, seconds count. So if you have the Pulm Crit doctors out there supporting virtual direct, what in the world is radiation oncology? What is different about that a Pulm Crit doctor can do virtual direct, but radiation oncology can't? We've been doing it for 4.5 years. And if you're truly concerned about that level of safety, at minimum, we need to start with promoting and advocating and mandating daily IGRT for all treatments all of the time. And if you're not willing to go there first, then I don't understand what we're even doing here.
Can physicians other than radiation oncologists be the ones providing direct supervision? What about PAs and NPs, CMS stance, and ASTRO stance? I think right now the stances are the same. It's a radiation oncologist. I think ASTRO would say that a radiation oncologist is the best to determine, when taken to the machine, whether or not one would favor target over normal tissue and make that decision. I don't know that a therapist would feel comfortable with that. I don't know that an APP would feel comfortable making that clinical decision. Certainly, if a patient is having a medical problem, it depends on the level of the medical problem, whether an APP or an NP could assess that problem and decide what to do, or whether that would need a physician, and unfortunately wouldn't know until the problem presents itself. I think to handle all situations, it's probably best to have a physician, a specialist in radiation oncology. I think that's ASTRO's position, and the position that we have heard the most from stakeholders.
This is going to be a double reaction, where it's me from now and me from the past. And just to make it very clear, this is talking about quality and quality of care. And this is very different than the supervision law. So the supervision rules, regulation laws, however you want to phrase it, is simply about fraud. It's about you're billing the government for something. The government is going to pay you, assuming that you met certain criteria. If you didn't meet those criteria, that's fraud. Simple as that. And so that's what the supervision is. Whether or not a person who is evaluating or seeing a patient is the most qualified or the best person for the job, or going to provide the best quality of care, those are different. Again, a license to practice medicine is not a driver's license, and Medicare regulations is not the speed limit. Okay. If you have a license to practice medicine, you can choose to not even bill Medicare. None of this applies to you. This is only for the people who are billing Medicare. And ASTRO is very confused about this. And I don't think it's intentional. It might be intentional, but I actually think everyone involved in this debate, we all want the same thing and we all mean it. I don't think there's anyone intentionally misleading or doing things wrong. I think there's just a lot of confusion. But ASTRO and CMS are not on the same page about this, where ASTRO can have this opinion, and that's what they should have. This is what ASTRO is for. ASTRO should be of this opinion. ASTRO is in the right and saying the right thing, and this is what they exist for. And when they do their APEX accreditation, even though I don't agree with certain aspects of it, they are well within their rights. They should be dictating. That should be in there. But CMS has been very clear about this. It's just a physician. It's just a person licensed to practice medicine. Further, as I am very fond of talking about, there is a whistleblower case in the state of Kentucky that has actually been appealed multiple times. One of the 5 counts in this whistleblower case is specifically this. It's the whistleblower, the relator, claims that radiation therapy needs to be supervised by a radiation oncologist, and the radiation oncologist defendants say no, they do not. And the relator, the whistleblower, cites ASTRO on this, brings their manual in, and the judge says, no, ASTRO is not making policy. It does not have to be a radiation oncologist per the Medicare guidelines, per CMS. It can just be any person licensed to practice medicine. And time again, the judge has ruled opposite of ASTRO on this, and because it's very black and white. CMS does not dictate that. It doesn't matter what specialty you are. And I think that needs to be very clear. And this is why I'm talking about the incumbents, the people who are quiet on this debate. They are going to do these things no matter what. If you are concerned about virtual direct supervision in terms of the job market, then you need to go pay close attention to what Anderson and Mayo and Penn and Sloan and Harvard and all those people are doing, because it is very easy to continue to proliferate in a way that restricts or does not create jobs for radiation oncologists, and it has nothing to do with this. The only people this hurts, this is just going to continue on or recreate the environment where it is a Ketam bonanza. It is a whistleblower free-for-all, and it's just going to hurt little Radonk, and big Radonk rumbles on. I'm also just going to randomly bring this up. The whistleblower technical name is, I pronounce it as Ketam, and it is spelled Quitam. And this has caused a lot of confusion. I think technically in the strictest of Latin, it should be Quitam, or you will hear that pronounced that way. And I'm aware of this. If anyone really pedantic out there hears this, but I'm going to continue to say Ketam simply because that seems to be the most popular way the actual lawyers say it. And this is just killing me that I have to make a note about this because this bothers me on the inside, but I just will say Ketam until the Attorney General stops saying it that way.
They're confused about antitrust. They're confused about supervision. I just have grave concerns. Like, these are the people who are supposedly offering comments and advocating things on our behalf when I don't think they understand the fundamental rules of the game. I think we all need to maybe have a course on this.
Every time we talk about direct supervision, we talk about a doctor seeing the patient in clinic face to face. We say, well, the doctor's got to be there to answer questions. The doctor needs to be there to look at a patient side effect. That is not direct supervision. That can be the result of someone being physically present and trying to meet direct supervision. But when that happens, there's no concept of supervision when you're sitting there in the room with the patient having a face-to-face. That is not supervision. It is something called maybe E&M or maybe personal supervision if you're doing a procedure or a diagnostic test. But to talk about that as being direct supervision, that is not direct supervision. And we conflate that every time.
Okay, Dr. Chabra.
Thanks, Shar. Just a quick question. So I understand, and first of all, appreciate the fact that you guys are doing this town hall. I think obviously there's been some comments about the timing of this relative to the letter, but my question specifically is, I appreciate what Samiran mentioned, which is very difficult to go either 0 or 100 or have carve-outs in terms of what the agency is trying to do. I guess my question would be is, rather than go in 0 or 100, what would have been the limitations or even the possibility of, changing the verbiage around certain codes that would have required the presence of a radiation oncology physician, whether it be at SIM or SRS or SPRT or weekly OTB, as a means of having sort of a better compromise in which you're not necessitating physical presence every single day. You still allow for virtual direct supervision, but then you also necessitate some degree of physical presence for those specific activities.
No, that's a thought to go specifically code by code. I will say that the American College of Radiology, for things that are image guidance, such as CT scans, they probably would have some input on that, and they're a much larger body. We did talk about percentage, like 90%. Of course, there needs to be a little bit of a precedent for that. The only precedent we could find for that was actually in the state of New Jersey. There's also a precedent too for non-enforcement, and that's what they use some for this rural, where they recognized that they couldn't be there all the time and they did a non-enforcement. So there are several avenues where it's not 100 or 0, and I think that's what ASTRO is advocating for, especially for clinically driven issues. But we hadn't discussed doing it code by code. But again, other than 77, which we feel, and I think most people feel strongly should have the radiation oncologists do, we'd not discussed simulation 280 or code by code. And I don't know, Dr. Michalski or Dr. Keel or Dr. Sandler.
Yeah, I think, no, this is a great question. And I think we're getting now into the issue of code construction, which is a complicated issue unto itself. And some of it, to be blunt, we're not at liberty to discuss. Neither would folks from ACRO ACR, because we signed confidentially agreements with the AMA to participate in the RUC process. But to go code by code, what you're discussing is actually putting all the codes at reevaluation. And to be honest, not only would we not come out ahead, we would lose a significant amount of valuation for every code. And it's not a question of how much, if we would lose, it's a question of how much we would lose, and it would potentially be catastrophic. So that issue, to be honest, that discussion, we have had it, and we've said, boy, anytime we get revalued, we rarely
come ahead. Yeah, I mean, that's a really good point, is that we've faced cuts year after year on things that we've done consistently. And if we let CMS open up all of our codes to reevaluation or revaluation, I am sure we will not come out on the winning side of that. And so we've been very careful not to open up that opportunity to CMS.
Really? Are you really saying that? Because what is rocker then? That you just described rocker. So rocker, for those who are still confused, is literally creating brand new M codes that are amalgamations of the existing codes. And it is inviting CMS to put us in our own bucket, completely take us out of the rest of Medicare, and still have us, for great reasons, use the same CPT codes and the M code. You are literally doing that. If you're so worried about that, no, it is not line by line going through CPT codes in the existing Medicare setup, but it is functionally the equivalent. You just described why you should not support rocker. And further, in the beginning, Yashar threw it in there, the ACR explicitly supports virtual direct. They literally have put out documentation and reached out to CMS supporting virtual direct for diagnostic imaging. ASTRO is on the opposite side of the ACR here, and I can't comment on the boogeyman of the confidentiality, but if you were worried about reevaluating our codes line by line, don't support rocker. That's what I hear.
One thing that often comes up in some of the online message boards is, why is there this distinction between rural and urban practices? And I put this as kind of a measured risk. If the alternative is not to receive radiation therapy, if the alternative is not to have the availability of radiation oncology services, well, then that's a risk to patients in that region. And so an exception to allow general supervision or non-enforcement of direct supervision was made by CMS years ago in order to have radiation therapy services available to remote locations. Whereas in urban centers where physicians are more available, we feel that risk-benefit ratio tips in favor of being available for the patients.
No one is confused about why the exemption would exist. People are confused about how you are going to define rural. Because while we talk about it as two distinct categories, rural and urban, there's not an actual singular unified definition of these things. And so the concern, at least that I have, would be if somebody thinks they are rural and engaged in virtual or general or whatever are not engaged in 100% direct supervision all the time. And then that practice is brought in a whistleblower case and they say, no, we're rural, non-enforcement. And then the government says, no, we disagree. You're not rural. That's the concern. Everyone understands why to have the exemption. It is how are you defining this? And because the term is not easily definable despite the way we talk about it.
Have you reviewed the Royals database for events since 2020? If so, thoughts about the review? We talked about this actually at the board meeting. They did go back to see if they could query the database, the Royals database, for information regarding this, and they just felt like they couldn't find, there wasn't enough information in there to be able to pull out whether these things happened when somebody was around direct versus general supervision. And so they felt like it wasn't useful. The ones, the specialists that run the database.
Because again, there has never been any concern about a safety issue that would have been stopped because a radiation oncologist was bodily, physically present versus if they had been virtual or not. And all these examples about side effects and other things, those are evaluation and management. And that is a very different thing. Because I would challenge any radiation oncologist. The only thing I can keep coming up with in terms of this is if the linear accelerator malfunctions and you have to turn it off or something. I don't know how to do that. That's why we have the medical physicists and we let the medical physicists be remote. There are many companies that run off remote medical physicists. And I don't know if anyone's getting training that I'm not getting, but I can't run the linear accelerator by myself. And short of that, I really need someone to walk me through an example that is not an evaluation and management example, which is separate from the supervision of the delivery of radiation therapy.
Let's see, let me go to the regarding daily imaging billing on the professional side. Does a provider have to be physically present in the office to approve their images in order to bill? This is like a coding question. I have Emilio on here. On the professional side, you do not have to be physically present in the office. When I am in my office, which is close, but not there, and you just have to view them by the next treatment. You don't have to be physically in the office. You have until the next treatment to review and see those. If you go home and do those that evening at home, you could still bill for those.
Just to double down and drive this home, because a certain billing company has said otherwise in some of their materials once or twice, she is correct. The work of IGRT review, the 26 modifier work of IGRT review, that is you as the physician reviewing the images, and that is done in a computer, period. There's no place of service concerns. There's no nothing. You can review IGRT remotely, wherever. That the work is you doing that in the computer. Now, your hospital, your institution might have policies otherwise, but there is no concern at all with remote IGRT review and billing. And don't let anyone tell you otherwise.
Yes, sir. Thank you guys so much for putting this on. I'm glad that we could discuss some of these points. I guess the question I would have is what Dr. Chhabra said before about going, 0 to 100 versus middle of the way. In 2000, Novitas created L36711, which required a physician to be present days on site. And since 2016, we didn't see a spike in any of the abuse, no adverse reactions, and it gives the practice and the physicians the autonomy and the discretion of whether or not they need to use that. Would you guys see that as a middle road or a guiding ground or quote unquote, I guess a guardrail? I hate to use that word, but a guardrail as an intermediary kind of common ground?
So 2 days a week in clinic?
Yeah.
We, as Kate mentioned, we were thinking if Medicare is open to a small range of flexibility, we were thinking like 90%. That's 1 day every other week out of the clinic, or 1 day or 1 hour out of a 10-hour day that you wouldn't need to be there. And I think that offers some flexibility to do some of these things that we were alluding to. But being gone from the clinic 60% of the time, I think that is a bit beyond a comfort level that I would want to see.
But I think, Jordan, to answer, at least, and again, we'd have to my unmute. No, I think the answer to your question, things are open for discussion. I mean, I think it's not all or nothing. Again, we need to find a common ground that works. And it's not just what we think works; it's what the agency thinks that works, right? I mean, we can talk about this all we want, whether it's a Novitas at 40%, or I know we're well aware of New Jersey at 90%. There's some issues with that. For those of you who don't know, that's about 400 pages worth of documents we're plowing through, because there was, I think it was ambulatory in 2000. It was hospital based in 2000 and ambulatory in 2007. And it has to do with the literally everything that they do. So again, it gets back to, they look at one piece, and I get it. We live in the radiation oncology world, but when we talk to the folks at the agency, which we do pretty regularly, they are very, very concerned about what they do here affects everything downstream. And lack of a better term, they're not risk takers. And so they look for precedent, and they like federal precedent. And we have, to be blunt, struggled with federal precedent, but at least the Novitas is a MAC. And so we're trying. I mean, it's not that we're not trying, and we're taking the feedback, and and we get it. Because like I said, I don't think there's anyone on this call that would think we've got to be there 100% of the time. And I'd like to think there's nobody on this call that would think we have to be there 0% of the time. How do we get this? It works for the agency because they're the ones who ultimately are going to make this decision.
I would ask, what is the more problematic nuance? On the one hand, you are asking for direct supervision with flexibilities, and you have to define those flexibilities. And if CMS is concerned about precedent, which is a reasonable concern, then if you start creating a rule or rules of exemptions under the term flexibilities and defining those flexibilities, then that to me has a much bigger butterfly effect than simply saying you need to be on site 90% of the time. Now, the question would logically follow, well, how is that being tracked? And so both of these create problems. If you don't want to do what the rest of medicine is doing, which is make virtual direct permanent, if you don't even want to stick with just general and acknowledge that general is permanent, if you want to turn back the wheels of time and say, we want direct supervision for just radiation oncology, except for these flexibilities, that's a problem. Also saying we want direct supervision for just radiation oncology and we want it 90% of the time, it's also a problem. I would argue that the minimal time on site is less of a problem because you are not spinning off this category of flexibilities and creating definitions for flexibilities. But that's just me.
One of the next questions is, are residents at academic medical centers used to fulfill supervision requirements? And no, they cannot. That is not done.
So just the disclaimer that I have not personally experienced or done this. Yes, it is. I can tell you right now that there are places in this country that do that. And actually further, depending on the state, it would be okay by the CMS guidelines. Well, one, right now we're in virtual direct in general, so it doesn't really matter. But two, even with direct, again, there is precedent that it just needs to be a physician, a licensed physician or a licensed person to practice medicine can supervise. So there are some states where a resident license is distinct from a independent license to practice medicine. So that's something else entirely. So like in Connecticut, I had my resident license that I used for my residency in internal medicine intern year and radiation oncology at Yale. That was through Yale, that was specific, and that's how Connecticut does it. Now, I also had my separate license, my independent, fully unrestricted license to practice medicine as a physician in Connecticut. So I had two licenses in Connecticut. And if I had been asked, and Yale did not do this, and I heard they used to do this back in the 80s maybe, but Yale was not one of these places. If I had been asked to supervise, it would have actually legally been okay. Whereas one of the other residents who didn't also have their own license, it would not have been okay because they would have only had the resident license. So it was not a full unrestricted license to practice medicine. Again, Yale did not ever do this. But no, it is absolutely happening in certain places of the country. And further, depending on how residents are licensed, it would actually be okay. But it doesn't matter because we live in a world of virtual direct in general. And it is all okay, but it is definitely happening.
Yeah, sorry, I dropped the call. I'm in the middle of nowhere, and that's what my question's about for rural locations. I may have missed it in the first 10 minutes, but what's the definition that we're going by for what is considered to be rural? What are the criteria?
Samir, do you want to address that?
Yeah. So this is something, believe me, we've also spent a lot of time on. And so ASTRO they took a pretty deep dive into this a few years ago. And there's a set of codes that CMS commonly looks at. I think it's the rural urban continuum codes, if I've got it right. And it defines, I think, 13% of the centers, accounting for 15 or 16% of the population treated as being in the rural setting. So that's the definition we're using. We're open to other definitions. It's not like we're married to that one. But again, we have to pick a definition that the agency is used to seeing.
Okay. And can you just say that again? And I'm just curious to know what it is.
Yeah. You know what it'll do is, if you don't mind, we'll put some more detail on that in the FAQs. And
Perfect.
That way I'm not butchering anything. And so if you don't mind, we'll have.
No, absolutely. Yeah, that's fine.
Because I don't want to anything that's not 100% accurate.
As before, I'm excited for this.
So what is the purpose of this town hall? Is it to pacify the masses? I only wish it could. Or will it be ASTRO, will ASTRO take actual concerns and feedback and amend the position? Well, I think I mentioned this in the RoHub chat that we've already done some of that based on the feedback we've received from RoHub or emails or other means of communication. So when we met with CMS, we obviously, they had our letter, but we then shared with them some of the concerns that members have expressed to us, including the issue of rural and a time factor that would allow some flexibility for people to be away for short periods of time, whether it be for clinical responsibilities like in the OR or committee work in the hospital. So yes, we are hearing the feedback. We are sharing that with CMS. The dialogue continues, and this is going to be helpful to us.
This is a common answer that I have gotten from them a couple of times. Recently, in the last few months, they met with my institution, the University of Vermont, to promote Rocker. And the response, because I was in my normal, not Burlington site, and my internet was spotty because, again, rural. And I had to duck off and didn't get a chance to ask. And so my chair asked for me about what changes have been made to Rocker based on all the feedback over the last year. And they did actually answer that question, which I have not talked about because I want to see if they're actually going to do anything about it. But again, here they give the same thing where we have one concrete item. We have the letter is the statement. And then we have these answers and we ask, what are you doing with this feedback? What is the point of this? And they claim, oh, we've definitely modified based on feedback. Okay, we have no evidence of that. And so what? Like, what does that mean? And there's just so much of this. What we said, they said, we're going to. There's very little in the way of verifiable information or verifiable documentation, but there's a whole lot of trust me, bro. Just trust me, bro.
I was just going to make one quick comment exactly to that. I appreciate making that comment. I guess the question to some of those that are putting on the chat here is, just seems like some of the comments we're making today seem to be creating compromises and changes to, I think, what the verbiage of the initial letter were, which were really to state that everything and all should really be under direct supervision, which I think is great. I just am trying to understand the timing of this now that CMS has seen the letter. Now we're having this discussion, which is important. But, what perception does CMS then have of our field? If we put out a letter, then we start having this conversation, then we start having good discussion, but then we go back and we tweak it around. The question is really just sort of where are we sort of standing right now as an organization as opposed to what the letter originally sort of.
Thanks for asking that question. And I will say this is that we had a very similar position in a letter to CMS back in September of 2023. And I think having posted this town hall, I don't think we would have had nearly 1/10 as many people joining us. We wouldn't have had nearly 1/10 the conversation on RoHub if we hadn't kind of shared that. And so I look at this as a good thing. We've engaged our ASTRO membership community, and we're getting feedback on a level that we wouldn't have expected or seen any other way. I think this has been healthy.
Yeah.
And we have many discussions with CMS. I mean, they know that these are complicated issues and controversial issues. And we've had discussions with them through the years. We know most of them. I mean, Edith, we know very well. And so they actually said, well, think about that. And then we'll have another meeting and follow up. And so they invite discussion and stakeholder discussions and know that, it's complicated.
I think, I think it's like anything. It's as they say, it's a complicated issue. We're fortunate that a lot of us have personal relationships with them. Our staff really knows them well, having been in place for 15 plus years. And they get it. This isn't like we just dropped in and we have a one-time card to speak with them. We can go back and speak to them multiple times. In fact, they want to speak with us again because we told them we're going to get more feedback and we're going to take it back. And we've already made some changes. And I anticipate we'll make some more.
I knew this was going to happen. If they're claiming that they barely get any sort of engagement, it's because they don't have any public facing anything. Like I literally have special like RSS trackers on the ASTRO website because I don't know when they do anything. And they have every time, as we all know, I'm very public with my questions to ASTRO. I never get any responses. They don't engage with me at all. There's a reason I do these things publicly. And it's because I know we all want to have these conversations and have these answers. I'm not saying people can completely disagree with me on the actual advocacy or opinions or whatnot, but the conversations need to be had. And so to make the claim that, oh, well, you guys don't care. And we thought that if we tried to have this conversation first, nobody would show up. So we're so happy we sent this letter and we set this whole community on fire with how angry people are because now we can have these conversations. This is what it takes. And to basically say, not only did they do that in part to kick the tires, I guess is how I would phrase that. They've also then followed up with CMS, circled back and had some additional conversations with them all prior to tonight and the very first time that the rest of us even got a chance to voice our concerns. Because they keep saying, trust me, bro, like, oh, most people say this, most people say that. How, what, where, when, why? Like if this is the first time, how in the world can you make the claim that you are representing the views of most or even anyone?
This was part of the reason I wanted to wait until I had the recordings and things to do this twice because it was confusing. So in that reaction episode, the statement about, the community wouldn't have engaged with us and we view this as a good thing that we got this much engagement. And so those were said at different parts that was said a couple different times. And then further, there's a chat that maybe I will talk about at some point. But so this was a Zoom meeting and there is an incredibly active chat. So for those who didn't know, but who are aware of, or for those who didn't go, but are aware of the nature of the Row Hub conversation and how spicy that got. Imagine the Row Hub conversation, but times 11. And so when you hear me reacting, that was the gestalt of all of those things, of the thing about engagement said a couple times by a couple of different people and the chat. But that was the general gist of what they were saying. And that was the best part to put that in there. And this has been the issue with ASTRO, and there's been a choppy couple of years, we'll say. So since starting in 2018, if you look at the tumult, and in 2018, when there was the high board failure rate and people wanted answers, they were very slow to non-existent in giving us answers. And basically the only thing we got was that publication in the actual sort of quality of residence was before all this, but there was something in either the newsletter, I can't remember, and then there was a just talk done by Lisa Kashnik at the ASTRO conference that year. And there was very minimal sort of conversation. And that's the issue about all this. If the perception on ASTRO's end is that the community is not interested in engaging or discussing these things, the perception on the community's end is that we don't even get the chance. And I have been involved in radiation oncology for a very long time now, but specifically this clinical side and being this focused on things. And we'll just start the clock at 2018. That has been time and time again. Like if they're saying they send 12 letters to CMS like they did earlier, I know where there's 2 of them, but what are the other 10 letters? Like, what are we talking about here?
How do they know that?
They don't.
And that's my other favorite thing was the lightning fast polls in the beginning were 7% of respondents were freestanding. So this specialty has been held captive by people in freestanding centers forever, basically, but at least the last 20 years. And it is the minority position. And to be clear, that's just a billing mechanism. Freestanding is not private practice. Freestanding is not community. Freestanding is not academic. Freestanding is not anything other than how you bill. And so you have these people with a vested financial interest, because if you look at the 21C and the Genesis Care people hold leadership positions within ASTRO and ABR, and it's the tyranny of the minority.
I'll do this as a future episode, but there is a very interesting lawsuit that details how all of this works behind the scenes with lobbying and how much power the freestanding centers have had in comparison to their minority position in the country. And by freestanding centers, I really just mean 21C, 21st Century Oncology, which turned into Genesis Care, and the individuals involved in that, and then their positions that they held in ASTRO, ABR, and ACRO as well. And it has really resulted in this sort of skewed focus, skewed priorities, which need to be addressed. And we've been dealing with those consequences for quite some time, but it is increasingly salient that we need to realign.
I'm just looking at the chat. It's a little hard. There's so many comments.
I know I'm getting three different chats in the Slido. So,
but one comment, Jeff, that we talked about was whether our interest in some form of direct supervision makes us a unique specialty in the House of Medicine. And I know you've had discussions with other specialties about this, and I was just wondering whether you could just comment on that.
Yeah, first of all, I want to be on the record that ASTRO is not against telehealth or telemedicine. I think it's a very important thing that has grown since the pandemic, and many of us use it for initial communications with patients or follow-up. But there are other specialties where direct supervision is really still important. I had a long conversation with our clinical chief of anesthesiology and the American Society of Anesthesiology. It's their position that direct supervision remains a very important element of the care they provide. You can imagine an anesthesiologist where they have CRNAs in different operating rooms is doing direct supervision. They're immediately available to those, but they can't even go down the hall and do other procedures while they're supervising. And so direct supervision in that environment remains very important. And, patients under anesthesia undergoing surgery, obviously different than radiation therapy, but there are still risks associated with the treatments that we I look at that as a specialty where there is some relationship between direct supervision and what we do.
What? So while he was saying that in real time, I was trying to find any sort of official position statement from any anesthesiology group, and I could not find anything in terms of the search I was doing at the time. It might exist, but so number one, yes, every single one of us, myself included, agrees that direct supervision in general is a good idea, and I do it myself. Even though I'm a staunch proponent of virtual direct in general, I choose to engage in what can be considered direct supervision, or I guess I'm physically in my clinic a lot. Most of the time that the linear accelerator is on, or I guess almost all of the time, but more importantly, even if it's not. And that is different than a federal regulation, a mandate, a law. Those are two different things with two very different consequences. And further, yes, it makes total sense to me that you would not want to have anesthesiologists walking around far away when a patient is actively under anesthesia. Those are wildly different situations. A patient who is coming in for a daily treatment if you're doing lung treatment, if someone's getting 60 gray and 30 fractions, the daily 2 gray treatment is incredibly different than someone undergoing a surgery requiring general anesthesia. I don't know if that's really the metaphor or the analogy we want to go with here, but again, nobody disagrees that there's a best way to practice medicine. Where the disagreement comes from is what should be mandated at the federal level by the federal government with all the consequences that entails.
A really quick question is whether we discuss this with ACRO or ACR, and do they agree with the position? And
yeah,
I'll defer to that. Yes.
And I know there are members from those two societies on, and if they wish to speak up, I welcome them to do. But yes, the members of ACRO and the leadership, we've been having frequent and long conversations with them, and there is a support for this position of direct supervision. of course, they too feel that there needs to be accommodations and exceptions. I don't know if anyone wants to say from our other members about that.
Yeah. Look, I don't want to put anybody on the spot that it wasn't, but I can tell you, many of you if you went to the ASTRO meeting, the ASTRO summit in Orlando about 3 weeks ago, I think they did a really neat job. It was kind of one of Dwight's vision to try to get all some of the society leaders on the podium at the same time. So we had, I think for the first time ever, we had the leadership from ASTRO, KAROS, ACC, AFROC, and ACRO on the stage at the same time. And we also had the AMA reps. And so this issue came up and everybody was in favor of direct supervision. And the ACRO survey, which again, it's not our survey, but it was 500. It was robust, 500 respondents and robust, and was 69% in favor of direct supervision.
Yet another trust me, bro, because the available on the record information, as it were, does not support that statement. Now, that might have happened, or a version of that might have happened, but I don't know what to make of this when only now is ACRO doing a poll, and I don't believe ACRO has yet to really make an official updated statement. They have things from the 2019-2020 era, sure, and I would imagine a lot of people who are on that town hall don't even know what AFROC is, but things like the AMA, the ACR, they are very clearly pro telehealth in general. The AMA has not specifically, that I can find, said we should make virtual direct permanent, but they have reams of documentation supporting virtual or tele everything. And the ACR specifically has come out in favor of virtual direct supervision being made permanent. Trust me, bro.
Yes.
Yeah, again, what's already been said, really appreciate you guys holding an open forum and having some discussion about this. And I certainly appreciate, Jeff, what you had said about, sending that letter was a way to get some involvement. But for our leadership, our national leadership as ASTRO, there's a lot, I think, more politically correct ways of getting involvement than sending a 100%, not a zero, a midway, but 100% stance to the agency. I'm in Idaho. We have a main hub, and then we have 3 other sites. And one of those sites is identified as rural, but the other 2 are not. But they're also not a full-time position for a radiation oncologist. And, it would have been great, and I do agree with what's already been said. Our leadership took a very hard 100% stance. And I would really like to create some dialogue for folks in our position where we always have multiple radiation oncologists working. And if, like one gentleman had said, you have a site that has a radiation oncologist 2 days a week, 3 days a week, and the other days you are absolutely available to discuss and to go out to that site if need be. And I think the analogy associated with anesthesia is a little off. I mean, we look at our chemotherapy colleagues, they're certainly not doing this. We're not protecting airways. If something happens, we're calling a code. We're having the hospital team code come here. And so I do want to create some dialogue about that middle ground. I feel like it has been cast aside. And there are a lot of people across the nation like us in Idaho that have one rural site designated and the other 3 are not. And they are not full-time radiation oncology positions. And so I'd really like to dialogue about what that means.
Thank you for that.
No, that's a good observation. And maybe thinking of being able to go, general, like we had said, for rural might be a consideration when we talk to CMS for situations like that. That's a good comment. Thank you for that.
Absolutely flawless. That was perfect and encapsulated what, I don't know how long this episode's going to be, but we're going to go with an hour and a half, 2 hours. She said in 1 minute what it takes me 2 hours to say. Beautiful. This is my concern. And this is the can of worms that you open if you do not thoughtfully engage with the government, with your stakeholders, before taking hardline positions. Now, a common refrain to this critique is they will say, they being members of ASTRO, we covered this in the letter. Let's read the passage from the letter that was sent. So it's at the bottom of the second page. And final paragraph is the delivery of radiotherapy is not similar to simply taking a pill or getting an IV. Rather, it is akin to surgery, albeit conducted daily as a series of treatments. Patients expect their surgeons to be physically present or immediately available to the treatment team during surgery. So too, radiotherapy treatment should be provided with a physician present to supervise. Of course, ASTRO believes that there should be practical flexibilities for radiation oncologists to participate in tumor boards and other clinical responsibilities for the good of patient care, as well as given latitude to ensure that patients in rural areas have access to treatments. However, as a general rule, direct supervision is the safest approach to high-quality radiation therapy. One incident related to virtual supervision would be too many. Now, the key of that is, again, what in the world do you mean by flexibilities? You have to define these things precisely, or you are opening up infinite whistleblower cases. Same with rural. And while I also describe radiation as similar to surgery, I call it virtual surgery. So this is actually word for word the kind of script I use in consults. It's virtual surgery, except my scalpel has an eraser button. So when a surgeon slips and slices an artery, it's very different than if I make an errant contour that I can Control Z or I can erase. And that's what drew me to radiation oncology, or one of the things, was that it seemed like Star Trek. It seemed like I could cure cancer from afar, from using a machine without ever touching the patient and cure cancer. That is incredible to me. And then I got here, and it is the most Luddite-driven, unfocused, defensive group of people I have ever met. And this fear-mongering, or if we're communicating this to the outside world, this is why we get into trouble. Whereas what we should be saying is what actually happens, which is we have built some of the most incredible software and protocols and policies and procedures and training and people that are just some of the best clinicians, dosimetrists, physicists, doctors, whatever. It's incredible. This whole enterprise is incredible. And it does not boil down to the 15 minutes a day that the patient is on the machine, because before you even get to that point, you should have been very thorough and aggressive and detail-oriented in how you crafted the radiation treatment plan. This is why all these upfront safety things exist, why we have multiple people, multiple steps, and peer review, and chart rounds, and Q&A, why physicists exist, why record and verify systems exist. All of these things are incredibly important, and I would argue there are many other safety improvements that we can be making all of the time. But the concept of physical body being in a undefined or fuzzily defined physical area while the treatment is being delivered this argument is ludicrous. Now, I say this because the radiation therapists are indeed there, and why ASRT is allowing this to happen just blows my mind. The radiation therapists are trained specifically for this. They go to school. They are of a certification. They have a license. They are the specialists who are physically responsible for the day-to-day under the supervision of the physician. Ultimately, the buck stops with the physician, but the therapists are there, and we do mandate 2 of them. Like, that is baked into the code. So the physical location of the radiation therapist is part of code construction, as it should be. And this is their special area. And how are you micromanaging this? And I still fail to think about what event would happen if something went sideways. How would a physical presence of a doctor help or fix it? Because the things I've seen are like machine errors. So it would be the machine doing something bad or wrong, or you hit the emergency stop button. The therapist should recognize that, because if the therapists don't recognize that, then it's already too late by the time, even if you're like right next door, because it's going to take something going wrong or somebody finding the doctor, then walking on over, depending on where they are. But at the end of the day, if something's not right, emergency stop button, just stop and figure it out. Whereas in surgery, if something's not right, if an artery is sliced, seconds count, minutes count. And that's the only thing I've come up with. Now, all these other examples of side effects of radiation treatment, those are evaluation and management things. Then we're just back into the realm of regular medicine. And yes, in general, many patients and doctors and other people in this relationship do a face-to-face interaction. It is debatable whether or not face-to-face interactions provide superior management, but it is generally favored to have face-to-face interaction for these clinical encounters. That's not what this is. That's something else entirely. That's the debate about telehealth. And this letter is 100%. We covered that in the letter. No, you didn't. This is very clearly, let's wind back the clock. Let's make radiation oncology in particular back to direct supervision, and claiming we wrote about rural and we wrote about flexibilities is, sure, the words are there. I'll give you that. You included the words.
Yes. Thank you, Dr. Yashar. I appreciate you taking my comment. And I know that Dr. Mahalski had just spoken about ASTRO and some other of the organizations that we all recognize this is a vital, important discussion that we're having. And so I really applaud the fact that there's this town hall. ASTRO, I think, is working on our own statement about supervision. And, I think that there are a lot of important components of what the letter that you all produced has to say. And, I'm going to just leave it at that. I think Dr. Cooley clearly made a good point that we had this survey that shows that 69% of the members from 50 states agree that there needs to be some form of direct supervision. So I'm just going to leave it at that, but I want to really applaud you all for having this town hall so that we can all discuss openly about this important issue. So thanks.
And before we move to Dr. Chaudhary, Kate, do you want to say anything about our process of generating these letters and communicating with CMS?
Well, often CMS will ask for feedback and will generate a letter. They'll say, we want data, or we want the societies to comment, and we can have a dialogue. And we send many letters, and most of them are posted on the ASTRO website. Cervical brachytherapy, say, we've been writing about for years. But usually it's in response to either a request for comment or when the rule comes out, not the final rule, but the interim rule, then we have a lot of comments on that interim rule until the final rule comes out later in the year. So that generates a lot of letters from us as well.
Thank you.
I believe Tarita misspoke. Tarita Thomas was the one speaking at the start of that cut when she said that Dr. Cooley was the one who had brought up the 69%. That was Samir earlier in the talk, of course. And so I'm unclear of what survey they were talking about. It sounds like it was just something that was done in person at this year's ACROS conference in Florida in March. But I also like how it was said that ASTRO writes letters all the time, and most of them are posted. Yeah, that's exactly my point too. Most of them. It's a lot of behind the scenes stuff that we're not hearing about. So if you're going to claim that you don't get engagement when you write all these letters, we don't even know most of the letters, it sounds like. It's a little interesting. Interesting little Freudian slip there. But no one disagrees that we should do whatever it takes to be the best doctors we possibly can be, to provide the best clinical care. Where we disagree is the mechanism. And this in-the-box, myopic, regressive sort of belief in direct supervision is not the way. It didn't work before. It won't work again. And what people don't realize is this was a brief moment in time. So direct supervision, as we think of it, only existed from January 2010 to December 31st, 2019. It was a 10-year period because, as I like to talk about, the supervision rules in general were created in the late 90s, early 2000s, thought to be applicable only to freestanding. Then CMS, quote unquote, clarified to the consternation of everyone in 2009 that, they meant everyone. And that caused a lot of ruckus. And then they did away with direct supervision in the hospital outpatient environment starting on January 1st, 2020. So for almost all of human history, even just in the 125 years since radiation was discovered, direct supervision has not been in place. It was a 10-year period of time. And the main thing that came out of that was whistleblower cases. Quality of care does not appear to be impacted. Safety did not appear to be impacted. This is not the norm. It might feel like it was the norm, but if your goal is safety, but if your goal is the workforce protection, but if your goal is protection of reimbursement and code valuation, this is not the move. This is not how you go about it.
Dr. Chaudhary.
Hey, thanks for doing this panel. I guess there's a few things. I'm glad that you wanted engagement. That's fantastic. I really hope that you're not implying that you needed to send out a letter, a public letter, just to try to get more engagement, because that seems, not the ideal way of moving forward as an organization, rather than doing this town hall prior to sending any formal letters, because it made it seem like all of us endorse your position to the public.
No,
Second,
I
think
appreciate that.
rule should be the only exception. I work in a major metropolitan area. Our practices are very different than academic centers in major metropolitan areas. In fact, I'd say more often than not, there are fewer physicians at non-academic major metropolitan areas than there are in academic. And, we're also, as you know, we're always the minority of the overall team in a radiation oncology department. All of their staff members are able to take shifts when it comes to doing work. Like, we are the only ones that are exclusively having to be there from lights on until lights off based on your position. And that's not really possible for anybody. Like, I don't see why a rural physician should get the exception, but let's say like a physician working in a major metropolitan area, but there's only one physician, would have to suffer because they're not part of the rural continuum. That you should have been making exceptions based on, if you only have one person there, like, am I not allowed to eat lunch because you want me to be there at all times?
Yeah, I think that speaks to the common sense flexibility and perhaps a percentage of time that one can be away. And it might require some creative scheduling to do things that are more intense and require your immediate presence at the machine than other things. So,
why we didn't do this prior to sending the letter?
Beautiful. Perfect. I completely agree. And they're about to answer again about the whole, why didn't we talk about this first? But I think Mudit's point is one that really gives away the fact that these people in these leadership positions are not clinical. And many of them have not seen patients in a long time, or if they do see patients, it is the vast minority of their job. And these are, because you heard Dr. Michalski immediately then goes talking about scheduling things that need to involve the physician. So for the rest of us who do this all the time, the rest of us who are in the clinic, there is a difference between routine external beam radiation therapy and things like brachytherapy or radiopharmaceuticals or SBRT. And we're already doing this. This does not need to be spelled out. Obviously, you cannot virtually supervise brachytherapy. That is not how this works. You can debate about SBRT, and there's more variation in that than I think the bubble of the scare up ivory towers realize. And same with radiopharmaceuticals. So I don't do brachy at my practice. We're not equipped for it. I do personally. I deliver radiopharmaceuticals. I personally do Xofigo. The way I wrote the protocol, because this is new to my hospital, is that I am the one physically pushing on the plunger. It is me. I cannot do that virtually. And I personally going to the machine for SBRT. So I ask for any SBRT, SRSI. That's how we have it arranged. And the schedule is arranged as such. So we have designated times for that. This is not to be spelled out. We know this. Okay. So we are just talking about the routine delivery of external beam radiation therapy, which is the majority of radiotherapy delivered in America. And Mudit's point is excellent. And it just goes back to my point about flexibilities, rural. These are very problematic definitions. And this was why it got changed in the first place. So when you are creating this multi-tiered system, it is very confusing and difficult to follow. That was the MedPAC report. That was why this got changed in the announcement in November of 2019. It was because when you are creating a system of rules and regulations with exceptions and exemptions and fuzzy definitions, this is the problem with Stark Law. When Stark Law came out, I think that it started to be drafted in the late 80s. It's a very noble intent. It's a very logical intent. But it is an incredibly problematic piece of legislation that has had to require multiple revisions over the years, and it basically just gets more confusing every time. And that is the issue with this, is the more convoluted. America is a big place. There's a lot of different geographies and situations. And so Mudit is down in Georgia, and he and I are both practicing radiation oncology. We both are from the same residency cohort, and the medicine part of it, we are very similar on. Our personal environments, me here in rural Vermont, him in urban Georgia, have very different requirements, very different quirks, and very different state level regulations. We're covered by different MACs. Vermont and Georgia probably have different state level legislation around radiation emitting devices. And what we're talking about here is CMS's federal regulation around billing CMS. And you should probably have that as bare bones as possible because of the variation in state to state and even variations within the states. And the last thing you want to do is create special rules and regulations with exemptions for one of the smallest specialties in all of medicine. That is a recipe for disaster. And clearly, many of these people who are promoting this have not been involved in and around whistleblower cases. And if you think you're safe, you're not.
We actually send a lot of letters. This one's obviously created a lot of furor. I guess since we send so many, it's a little bit unexpected, but we're listening. That's why we're having the town hall, is to listen and then to go back and talk to CMS again.
We do it. And so we do these grassroots advocacy efforts on things. I remember PAMPA, which I think for those who don't remember, and probably many of you never knew that it happened. We were very, very engaged in that in 2015, and it strictly affected the freestanding centers, and it basically averted an overnight 20% cut to freestanding centers. And, it was really a crisis if you owned equipment and it didn't affect anybody on the hospital side, it didn't affect professional fees, but we felt it was bad for the field of radiation oncology. We had about a 3% engagement rate from the membership, and we tried everything possible to get engaged. And so this obviously did create significant response, but generally speaking, when we put out a call to the membership, it just goes unanswered. That's the honest answer. Yeah, I guess obviously we had a crystal ball to see how much this would have created, but we would have handled it differently.
Wow. What he's talking about there is exactly what I was alluding to earlier with PAMPA affected freestanding centers. Now, there was a lot of engagement from relevant parties, and you can find this all in lawsuits because the main lobbyist who prevented those cuts on behalf of 21st Century Oncology was promised a several $1 million bonus because he prevented this from going through. And he was not paid because when 21st Century went through bankruptcy, well, that's a future episode. But yes, Samir, you answered your own question. Freestanding centers is the minority. You did not get member engagement because it did not apply to the majority of us. Why in the world would you expect to get a lot of engagement from an issue that does not affect the majority? Further, that specific issue, 21st Century Oncology and Genesis Care are unique entities. I'm going to be very careful on how I say this. Many people in the radiation oncology community have very concrete opinions about those companies. And if you come to the community and say, hey, this thing is happening that's a threat to 21st Century Oncology's bottom line or Genesis Care's bottom line, you are not going to get circle in the wagons. You're not going to get a lot of excitement because the consequences of things that company has done have been felt by us and will be felt by all of us forever. It should not be a mystery. And beyond that lobbying effort, that was bought and paid for by 21st Century Oncology. If you try to go find what other role ASTRO had in PAMPA, let me know if you can find any sort of real documentation. I would love to see it because otherwise it's trust me, bro.
I will say, though, I think I saw some stuff in the chat. Did you talk to the other organizations? The answer is unequivocally yes. I mean, again, I don't want to get into and put other places on the spot, but Jeff Howard and I meet with the ACRO leadership probably every 6 to 8 weeks. Sometimes it's more often for, 60 to 90 minutes every other Friday around this time, to be honest with you. And we talk with the ACR leadership pretty frequently. And so this has been a frequent topic of conversation. I don't want to put words in their mouth, so I want to kind of stop saying there. But the notion that we did this in a vacuum is simply not true.
No, this, like Rocker, you did in a vacuum. And because if you think that having curbside conversations about issues and then in the only sort of on the record, public facing things, you do it yourself, and you don't get buy-in from your colleagues, then that is doing it in a vacuum. And still to this day, Rocker exists in a vacuum. We're about a year on now. still to this day, there's been no other official statement of support regarding direct supervision. And we must just have very different definitions of what in a vacuum means.
So then, Mohammed Khan, you have your hand up.
Yeah, quick, a couple of things, just more on, because there was a House of Medicine question. From the AMA point of view on this, the AMA has specifically said, and it's not always the AMA will do this because it doesn't like to talk about specialties. It likes to talk about things broadly that reflect the entire House of Medicine. But the entire House of Medicine felt that CMS got it wrong. That with the field of radiation oncology, with another field like hyperbaric oxygen, that, you know what, when you give high energy radiation to a patient, a doctor should be there. It was quite clear. And this was, the AMA House includes representatives from every state. It includes representatives from every specialty society. It includes surgeons. It has U.S. Oncomedical, other people with monetary interests all over the place. But they all, when that rule came down, that they were removing direct supervision from high energy radiation being delivered to patients, the whole House of Medicine said it was kind of a no-brainer. You need a doc there.
No, I think he's a little confused there, because there certainly was an uproar from the whole House of Medicine. And that was back in 2009 when direct supervision was brought in for everyone. At that point, you certainly had the AMA or the AHA and several other organizations in an uproar over CMS mandating direct supervision for hospital outpatient departments. And there is significant evidence and documentation of that. There's actually a trade journal called Inside CMS, I believe. I'll try to link some of it up. And they run these sort of stories about this. When direct supervision was brought in for everyone in 2009, 2010, there was an uproar. Now, granted, the pandemic changed sort of priorities and voices and things, but there was zero pushback when general supervision was brought in on January 1st, 2020. Seriously, just go get on the Wayback Machine, get on Google, go see what happened when direct supervision came in 2010, and go see what happened when general supervision came in 2020. There's a stark difference.
So that was the first part. And I think even within our own specialty, we get used to things. It doesn't seem a big deal to us. High energy linear acceleration. We do it all the time. We prescribe these ridiculously high doses to patient, but other doctors get it. And I'd hate to be in court one day with a patient that's harmed and have to see who gets that, right? So that's the other side of this. And I think when your leaders from every society, every specialty society, there's some nuances around there. But by and large, even the vote we had today, the vote we had in the survey across the board from all 50 states, it's quite clear. We want direct supervision. How can we nuance that? That's going to be a question. Now, CMS does not necessarily like to think in nuance. Shamir said that, right? So we may be faced with, we would like to try get some nuance, but are we better off with direct supervision of our patients or not? That may be where we come. And we have to choose that. And I think we pretty clearly see the vast majority of radiation oncologists want direct supervision of our patients. And it's just how much more can we get to make it a little more flexible? And you got to realize you're dealing with CMS that doesn't want to set precedents for all other specialties, doesn't want to do something that's too much of a headache that they're going to have to figure out and think about and chart hours and clock. And so we'll have to see the best we can do to get the flexibility we want. And maybe the old precedent of non-enforcement. We want direct supervision, but you agree to not enforce in a lot of areas. Maybe that's where they'll end up because there's definite federal precedent for that. They've done it for decades. That's just an idea and some thoughts on it. But just to get an idea, it's not us deciding what we want. It's us deciding what CMS will do. And right now they've done something that puts the entire specialty in danger, significant danger.
For the record, I think he is absolutely incorrect. I do not agree with him. Many of us do not agree with him. This is not dangerous. That is a dangerous thing to say. And I certainly hope that he is not saying that to the AMA or to really anyone. Honestly, I don't think that is true. I don't think most of us think that's true. And that's a really regrettable thing to have said. And I hope that is not the message that is being delivered on my behalf.
Thank you, Dr. Khan. Do you want to remind us what your role in the AMA is?
I'm the delegate from ASTRO to the AMA. So I'm one of the delegates that represents radiation oncology within the House of Medicine. And ASTRO also has excellent delegates, right?
Along those lines, there was a lot of astounding things tonight said at the very end with Dr. Khan, who, if I'm going to paraphrase what he said CMS is dangerous. Medicare is dangerous.
Yes.
Was that everyone came out against CMS's change from the direct to general supervision, because you've got to have a doctor around when you're giving high energy ionizing radiation. And for CMS to do that, it was unsafe. So all of Medicare, CMS is an unsafe organization making rules that put patients in harm's way.
So that is the end of the relevant portion of the town hall. And again, credit where our credit is due. It was an actual town hall. It was predominantly discussion, and hopefully this is the trend moving forward. It remains to be seen what ASTRO will choose to do after all this, because I've never seen anything like this in radiation oncology. The amount of concern, consternation, energy in opposition of ASTRO that this has generated is the biggest I've ever seen. And it would behoove them to take note of that and to listen. And I know people have already individually authored their own letters to CMS. I am planning on doing that myself, probably more as a group. And there's other movements of people who will be authoring letters together, because that is an option for all of us. So if you disagree with me and you are on board with ASTRO, you can make your voice known. If you disagree with ASTRO, not only will there be opportunities to author letters or talk to your representatives as part of a group, you can always do it on your own for anything all of the time. And I will try to get that information in a way that if you don't know how to do that, to be able to easily do that. Because again, a bigger point, my point always is that, agree with me or not, staying silent is a choice. If there are issues out there that require an opinion, or if there are issues out there that there are two sides to, staying silent is still making a choice. You're making a choice in a position by not saying anything. You can disagree with me. It seems really ridiculous to say. I know people disagree with me, and for far too long, we have let ASTRO drive the boat. And if you look at radiation oncology today in 2024 compared to radiation oncology 22 years ago, we are not better off, not by a long shot. Our technology is better, our treatments are better, our outcomes are better, the strength and the quality of our physicians are better. Everything is better in that sense. But the one thing that isn't better is the meta-radonc, the macroeconomic issues, the job force, the reimbursement, the regulations. Those things are not better. And a large part of that is through the anhedonia, is through the indifference of engaging in political issues. And I know it's uncomfortable, and we have a very weird culture here in radiation oncology, and sticking your neck out is not comfortable. Take it from me. If I had my way, I would just be talking about arthritis all the time. Or I know it might appear differently. I don't really enjoy conflict. I don't seek out disagreements, but this is the career I wanted to choose for the rest of my life, and that I thought I had chosen for the rest of my life. But when it is evident to me that the organizations and people who are supposed to be looking out for my interests in this career, and by extension, all of us and our patients, and they are making the choices they are making, I am obligated to engage. And ultimately, I know that I will be just fine if I have to leave radiation oncology, but that was not what I signed up for. But if we keep going down this path, it is not going to be a viable career option for most of us. And the consequences of that on the thousands of physicians, but more importantly, the millions of patients who get radiation in this country every year are vast. And get involved. And ASTRO, do better with your public relations.